guys, so this is part 3 of the CS2 module. It's also part 3 of the BLS course. So if you haven't seen part 1 and part 2, please go watch them. So this is going to be about the BLS sequence in infants and in children. So let's define children and infants again. So children are between the ages of 1 to puberty. And infants are anyone less than 1 year old, excluding the newly borns. So just to quickly talk about the signs of puberty, because I didn't get to talk about this in the previous videos. So when you see a victim lying on the floor unconscious and you want to check if they've hit adolescence, if they've hit puberty, in males, what you can look for is like any signs of facial hair or chest hair or axillary hair, so armpit hairs. And with females, you could look for breast development, but obviously sometimes, different sizes and, it's difficult still. So again, you could look for, hairs in the armpit. The sequence for children are really similar to that of the adults. So if you want to just skip ahead, you could do that. But I'm just going to quickly run over it, just really, really quickly to remind ourselves of the BLS sequence for adults, and this also applies to children. The first thing that you do is you need to verify the scene, make sure that it's safe for the victim and for yourself to perform CPR in that specific scene if necessary. The second thing is you check for responsiveness. You need to look for tactile and verbal cues that they're unresponsive. So tactile stimulation includes shaking the shoulder, shaking the victim, and then verbal stimulation would include just shouting something like, "Hi, are you okay?" And if the victim is not responding to any of the tactile and verbal stimuli, then you need to call for help and activate the emergency response system. So that could be like dialing specific numbers if you are outside the hospital. And then you need to assess for breathing and for pulse simultaneously. So for breathing, we need to look, listen, and feel. So we look for any signs of breathing, which means that you look for that rise and fall in the chest, which indicates that the patient is, breathing. And you need, if you can't see that, because for example, it's winter and the child is fully covered, with layers of clothing and a thick coat, and you can't really see that, what you can do is to kind of like put your face closer to that of the victim, and you can feel if there's any air coming out of the mouth or the nose. And you could also try hear and listen if there are any breath sounds. For adults, we usually palpate for the carotid pulse. For children, we usually still use carotid or femoral. And for infants, I think it's brachial and femoral. Then your next actions would depend on your findings. So if the child is breathing and has a pulse, you just stay with the victim and make sure that the level of consciousness doesn't change, that the pulse does not disappear. So stay with the victim until the emergency services arrive. The second potential scenario could be that there is a pulse, but the victim is not breathing. So what you do in this instance is you provide rescue breaths every 5 to 6 seconds. So that's 10 to 12 breaths in a minute. And you need to deliver the breaths over 1 second. So you just look for that rise in the chest, which means that the breathing or the ventilation that you've given is effective. Stay by the victim's side until the emergency medical services arrive, and keep checking the pulse every 2 minutes. And be prepared to deliver high-quality CPR in case the situation changes, in case the victim loses pulse. And you have to look for signs of poor perfusion, because the situation can deteriorate very quickly from here. So look for signs of poor perfusion, including color changes in the skin, especially in the periphery. So the hands and the feet, they can turn pale. And in the later stages, they could be cyanotic, so they could turn blue. And you have to feel the temperature of the peripheries as well, of the hands and the feet. If they get cold, then again, that's a sign of poor perfusion. And the third scenario, and probably the most critical scenario, is when there is no pulse and no breathing. In this case, you start CPR and then you check the airways if if there's any obstructions in there. If the victim is a child, you could either use 1 or 2 hands. It really depends on the size of the child. As long as you could achieve the sufficient depth of compression, so that's 1/3 of the AP diameter, 1/3 of the anterior posterior diameter, then using one hand. If you think you could achieve that using one hand, then by all means use one hand. If you think you would need more force to achieve that depth, then use 2 hands. And when the AED becomes available to you, then use that ASAP. AED would give you instructions, so you just have to follow the prompts. So after the shock is delivered, or if it says no shock needed, then you immediately resume CPR and doing the rescue breaths until the medical services, the emergency services arrive, or until the victim regains consciousness. Just to clarify, the universal compression rate for all adults, all children, and all infants is 100 to 120 compressions per minute. It's only the ratio between compressions and rescue breaths that would change. So if there's only one single rescuer at the given scene, it would be 30 to 2 for adults for one rescuer. It would still be 30 to 2 for one rescuer in children, and it would still be 30 to 2 for one rescuer for infants. This will only change if you have 2 rescuers. So if you have 2 rescuers and you're trying to resuscitate a child or an infant, then the ratio would be 15 to 2. Moving on to the BLS sequence for infants for one rescuer. So again, we need to place the victim on a flat surface and check, obviously, the environment, if it's safe for the baby and safe for us to deliver CPR if needed. And then what we do is, again, we provide tactile and verbal stimulus to check for responsiveness. It's really not advisable to shake the infant, to shake the baby. So what we do instead is we rub the hands or the feet of the baby. And then for verbal stimulus, because they really would not understand us, just say anything. As long as it's loud for the baby, for the infant to hear, then that's fine. You could still say, "Are you okay?" It's, just to elicit a response from the child, like a cry or just anything. Once you've verified that the infant is unresponsive and there's no signs of breathing or no pulse, then what you do is you move on to compressions. So there's 2 different ways of doing this. You can either use the 2-finger technique, so we use that, or we use the 2 thumbs encircling technique. So it's really hard to demonstrate without like a dummy here, but I will try, see if I could film a video for you guys when I do the practicals. For the 2-finger technique, what you need to do is to find the baby's nipple line, and you place your 2 fingers just below the nipple line. Like I said, the rate would be similar to that of the adults, 100 to 120 compressions per minute. It's important to get the depth right, which is 1/3 of the AP diameter, and it's important to look for that chest recoil, allowing that chest to recoil after each compression. After giving 30 compressions, you need to give 2 rescue breaths, and it's gonna be this cycle if there's only 1 rescuer. If there's 2 rescuers, then the ratio would be 15 compressions to 2 rescue breaths. So the second compression technique for infants is called the 2 thumbs encircling technique. So what you do is you basically put your thumb, so locate the nipple line, and you place your 2 thumbs just below the nipple line, and then you start compressions. Yeah, again, same rate, 100 to 120 compressions per minute, and get that depth right, 1/3 of the AP diameter, and watch for the chest recoil after each compression. And this method is preferred if there are 2 rescuers, because one could just be in charge of the compression. It's not that tiring because the infant is quite small, and so one person could just focus on the compressions and the other person could focus on the airway and the ventilation. So with really tiny babies, with really small infants, what you might have to do is to overlap your thumbs, because their chest is quite small. And if you feel ribs, don't compress there. Make sure that you're compressing on the sternum, the breastbone. And yeah, so you could do this instead of doing it like this. I will try film a video when I go do my practicals so you guys can see. The two thumb encircling technique is preferred over the two finger technique, just because this may provide more consistent rate and depth of compressions, and therefore generate higher blood pressures and more effective compressions. So talking about airways, in infants, it's really not advisable to tilt their head back. This might actually be counterproductive because tilting their head back too much may actually close the airways. So just keep their heads in neutral position. So most of the time when infants and children develop sudden cardiac arrest, it's usually secondary to respiratory failure or shock. This means that the oxygen level in the body might be reduced even before the onset of the arrest. So this is why it's really important to give both compressions and rescue breaths for infants and children to increase their chance of survival following a sudden cardiac arrest. So for infants, the rate of ventilation should be 1 every 3 seconds. So that's twice that of the adult, which is 1 every 6 seconds.